Good afternoon, everybody. My name is Carrie Wood. I'm the state rep from the 29th district, and I am chair of the Insurance and Real Estate Committee. This is the Certificate of Need Task Force meeting for Friday, December 2nd at noon. This is live on YouTube and also on Zoom. I'm getting some background noise. Are we all set? Can everyone hear me? Okay, great.
Representative Wood, I'm sorry, I think you got the date wrong.
Oh, yeah, sorry. This is November 30th. I'm sorry about that. That's right. We have two meetings. This is November 30th, everyone. Thank you for correcting me. Don't want to have time go by that quickly for sure. So why don't we start with having everyone on the call just give an introduction of themselves and their titles, and then we will move on to the next item. We can start with Dan Keenan.
Dan Keenan, Vice President, Advocacy and Government Relations, Trinity Health of New England. Nice to be with everyone.
I'll go ahead. I'm Thomas Farquhar. I'm a practicing radiologist and the president of the State Professional Society, the Radiological Society of Connecticut.
Hi, Gina, I'm Chief Strategy Officer at New Advance Health.
Hi, I'm Pat Charmel. I'm the CEO of Griffin Hospital. Good afternoon.
I'm John Brady. I'm a registered nurse and the Vice President of AFD Connecticut.
Anyone else on?
I'm sorry, I joined a few minutes late. Sue Lagarde, CEO at Fairhaven Community Health Center in New Haven.
I'm Laura Manzione. I'm the Health Systems Planning Manager at the Office of Health Strategy.
I'm Jim Carson with the Connecticut Insurance Department.
Good afternoon. I'm Dawn Johnson. I'm the president and CEO of DHG Services, a consulting firm in Connecticut. I'm also a registered nurse.
Okay, that looks like everyone. Thank you, everyone, for joining us today. So basically, just to give everyone some background, what we've been doing is having just some offline discussions on, breaking down part of what the task force was directed to achieve. And today I was hoping that we can get some presentations. I know we got one from Dan Keenan. So Alex, if you would like to pull that up, we can get started, and Dan will take it from here.
Thank you, Madam Chair. Am I off mute? I said appreciate the opportunity to be with you, and I think Alex is starting to share our presentation now. I'm going to kick off the report out from Working Group A, but I'll kind of introduce the other members as we kind of move through this. But we do consider this to be a preliminary recommendations from Working Group A. We've met several times, but anticipate meeting several more times before we do a final report out. If we move to the next slide, just to make sure we all have the same kind of context for the work that we're doing. I have here the charge that we all have for the CON task force to study and make recommendations concerning certificates of need. And under the direction of the chair, we divided up into work groups, and each work group took responsibility for one of the 10 matters that were before us. And I have highlighted numbers 1 and 4 here, which Working Group A took responsibility for. And if we move to the next slide, I just highlight them for what we're going to report out on. So our working group has been focused on studying and making recommendations regarding 2 issues, one being the institution of price increase cap that is tied to the cross growth benchmark for consolidations, and then setting standards for measuring quality as a result of consolidations. The members we have highlighted below, I think everyone's introduced themselves, and everyone who can see who's in our group. And as I indicated, we've met several times. We've had very good discussion, done some due diligence. We've reviewed the 2017 CON task force final report. We reviewed recent OHS agreed upon decisions regarding CON and what those look like. specifically in terms of price caps. And then, as I indicated, we've had some good discussions of our group. So if we do move to the next slide, we have highlighted here our first charge, and that's the potential institution of the price cap, and just highlighted some kind of bullets here for us to look at. But Pat is going to take the lead on this. We may have others jump in as well, but he's going to take the lead and kind of highlighting some of our thoughts so far from our work.
Yeah, thank you, Dan. Just in terms of the institution of a price cap, we talked about the intent of the cost growth benchmark, and I know there had been discussions in other forums about the intent. Our interpretation of the question as to whether the benchmark should be used in decisions about a specific service request related to in a CON proceeding. And the cap in the cost growth benchmark was never intended to apply to a specific service or service line. It's an aggregate cap applied to total healthcare spending growth in an institution. So just as a practical matter, it really mechanically doesn't apply at this level. So we understand why the question is being asked. And of course, if a particular service request has a broader impact that might trigger the cap on an aggregate level, that potentially is relevant, but that would be very difficult to determine as part of a specific proceeding for a service request. And I know that OHS has already begun to have some conversations about this in CON proceedings, but I think folks who understand hospital operations well and have actually been through the CON process, and all three of us, Dan, Jean, and I have that experience, understand the practicality of this. So from that standpoint, and again, we're taking a very literal interpretation of the question. So if the question had a different intention, we could refine the question, but our response at this point related to that question is it's really not appropriate. All right, Jean and Dan, I hope I did an okay job of kind of representing our views on this.
Yes.
Yeah, I think you did, and I know Dr. Farquhar may have some kind of thoughts as well, because he has had some kind of specific involvement. I don't know, Dr. Farquhar, if you have any.
Yes, and I didn't mean to exclude him. He's experienced in the CON process as well.
Yeah, no, I didn't have anything to add specifically here, but I echo Pat's comments that it may not apply to specific, once you drill down to a specific service line.
And I could probably just offer, maybe one or two other comments based on experiences that I've had in Massachusetts. And Trinity Health of New England operates, along with our hospitals in Connecticut, has a hospital and physician practices in Massachusetts where there has been a cost growth benchmark in place for, I think close to 10 years now. And that is similarly focused on trying to control overall healthcare expenditures, but it does kind of leak into other areas that and we've discussed this in our call, where it wasn't specifically intended, where you may have maybe an extremely low cost service being kind of scrutinized through a CON process, and it may not be prudent to subject that type of transaction to the same kind of level of a cost growth benchmark as another service. So we don't think kind of a broad application of the cost growth benchmark limit would be appropriate. But as Pat pointed out, it does depend on specifically to the question that's asked. But that's where we ended up. So.
And I guess one other thing, OHS. In a normal course of business, in the CON process will ask about the efficiency of a requested service. So in the absence of applying this, they still have that as part of their purview. So I think they have the tools that they need to ensure that a requested service, is being provided as efficiently as possible.
So we could probably move, we could take questions after probably the next component of our presentation. So if we move to the next slide, then this was the second, charge before us, and turn it over to Jean and Thomas to present out on this. But this was the second and final question that we were posed with.
So Thomas, I can take the first two bullets and then lead off. So as you can see here, the work group did discuss the quality elements of the CON process, and we do appreciate utilizing the CON process to maintain and improve quality. We are supportive of considering using CON to allow the Office of Health Strategy to consider quality of services. The caveat here, as we've noted, is that we do want to make sure that they are based on nationally recognized best practices and guidelines. And so as we move forward, certainly open to that, it would very much be dependent on the definitions of how we would utilize quality, however. And so with that, I know that Thomas has a particular perspective, given he is from a particular clinical service. And so we'll talk about the level of expertise perhaps that's necessary as well. So Thomas.
Yeah, so Jean had touched on it, but there are a lot of already measuring quality in medicine is actually pretty difficult, and there have been lots of attempts to do this on a national level, from Joint Commission to CMS to all sorts of other different measures. And so we had some concern that if we were developing in the state of Connecticut our own new measures or standards, is this something worth reinventing the wheel to do that again, or would we be adopting the standards that are already in place? And then furthermore, we wondered if there was the bandwidth for OHS, to continue to follow these measures on an ongoing basis. So rather than having the CON process be a single time point at the time of application, was the intention, for example, after a consolidation or a change, did you want to see whether quality of care went up or down or stayed the same? And that would require sort of serial monitoring. And to our knowledge, there's no infrastructure or manpower in place to continue to remeasure this type of thing on an ongoing basis. If that was to become possible, then obviously there should be some sort of a baseline that's established as we gather data in the state using these quality measures. And then we would want to remeasure them in the future and look for improvement over the baseline. Because obviously with any change, the hope would be that the quality of care certainly wouldn't decrease, but would go up. And we really do feel that this would be a new, almost a new function for the Office of Health Strategy, and we would want to ensure that they have the expertise and capacity to be able to do this. And then the last bullet mentions that we really would want this to be a level playing field that would apply across, all providers, subject to the same rules, with this type of quality reporting, hopefully some sort of public reporting, or at least make them somewhat accessible. So not only measuring them at the initial time point, but also looking at them going forward.
Do we want to open it up to questions?
Sure.
Okay.
I'd be happy to do that. And
if you have a question, please just select the raise hand feature. I do have a couple questions based on this slide, so you can leave the slide up. The bullet number 2. Does the certificate of need process need a panel, like a peer review, like a panel of experts like yourselves or some sort of volunteer board to participate in this quality discussion in unison with Office of Health Strategies? Would that be I mean, considering we all know that there is a bandwidth issue at OHS, I feel bad even setting up meetings because we're, constantly taking, their time, away from doing the work that we are asking them all to do. Is there another way we can look at this? Is there something similar that exists, that's out there that we can point to that works, that would assist OHS, but also provide that expertise of boots on the ground perspective that, we don't necessarily have if we're state employees?
I mean, the CON process already asks questions that get at quality. You typically, when you write a CON application, you do talk about your quality elements. And so if there were a question, depending on what type of application it is, if there was a standard, please speak about this type of quality benchmark that's nationally recognized, I think it could just be built in. And then people would just need to speak to where they fall along those lines or how they are going to seek to improve it. But Pat, Thomas, and Dan, you may have some additional thoughts here.
Yeah, Jean, I as you began to speak, I was thinking the same thing. If it's not already there, that could be clearly built into the standard questions, identify how you would measure performance, including clinical quality for the requested service, and can you provide a baseline? And how would you measure that over time? And then again, what's the evidence for that particular measure or set of measures? So that OHS wasn't put in a position where they have to become the expert. They might have to check the references to make sure that what we're identifying as the appropriate measure is indeed accurate. But the panel may just bog down the process. And they would be doing the same thing. They would be going to the literature and finding the accepted standard, I think, or an evidence-based standard.
Okay. And then the level of the playing field, can you elaborate on that just a little bit more? I mean, you're basically saying, I think it's much more simple than I originally thought it was, which is you're applying the same standards in terms of analysis, across all, providers. But I just want to make sure that there wasn't some other, anything else that you were trying to get at with that bullet.
I think what the group is also trying to get at is that many of these regulations apply in large part to hospitals and health systems, but there are several other healthcare providers that exist that are not subject to CON regulations, and they should be. If we're truly trying to limit the growth of total healthcare expenditures, increase the quality and the value of the entire healthcare system, those other healthcare players should be subjected to the same rules that hospitals and health systems need to abide by, especially if we're talking about quality and cost here.
I agree. How do we dive into that a little bit more?
So Dan, you were going to say something?
Yeah. Rep Wood, just to add maybe a little bit more to what Jean had reported, though we did include this dot point under the question for quality. We thought I think we agreed that it was more universal than that, even to the cost growth benchmark question, that utilizing the certificate of need process as a tool to try to maintain or control costs and improve or maintain or improve quality is a goal that we support. But we support it in the context of kind of looking at the changing, healthcare ecosystem here in Connecticut and across the country, where there are many different entities or players entering the market who may not be subject to the same rules. So it's something we don't want to create an artificial burden on certain providers of care, hospitals and health systems that others aren't subject to. Not in a, we don't see it punitively want to apply to others, but just to make sure that everyone's playing by the same rules. So it does, kind of create a larger question as to the, how the CON program could be utilized more comprehensively.
Okay. Great. Let's see. Any other questions out there? John Johnson.
Yes, I wanted to just make sure I understood the recommendation. It sounds like the recommendation is that there is an opposition to including a measure of quality in these consolidations. There isn't any opposition to new standards and measuring quality on an ongoing basis. There is a request for equality to be applied across organizations. So everyone should be treated the same way and everyone should have to report quality. I guess that's my read of it. I just want to confirm my read of it. I think, when we consolidate, we should look at, what was quality before the consolidation and how has quality changed as a result of the consolidation. Because at the end of the day, this is really about improving care and making sure outcomes improve. So I guess I just want to confirm my assumptions about the recommendation, because I don't see recommendations. I see we are supporting and we are appreciating, but I don't see actual recommendations.
And Dawn, thanks for the question. I can jump in and let others comment as well. But just to highlight one, that these are preliminary recommendations, and so we do not consider to have finished our work. So this is a kind of a work in progress. But I think your assessment about where we as working group A, in terms of our thought process, I think your assessment is accurate in how you've stated it. But we haven't come to final conclusions. But based on the work we've done so far, I think you have an accurate assessment of what we have reported. And I can ask Jean or Pat or Thomas if they have comments as well.
No, just, realistically, this has been done over 2 or 3 months here. So just a very compressed timeline. And so you can imagine trying to find time for the group to meet, which is why we are emphasizing that it is very preliminary. So we recognize the fact that these are not fully fleshed out recommendations per se.
Yeah, and Dawn, the only thing I would add is I'm not sure that in our deliberation, and I'll let my colleagues speak to this, that we were limiting our thinking just to consolidations. So we were talking more broadly about the CON process, right? Which
I would agree, yes.
I agree. And obviously, I think one of the key questions here is to do the ongoing monitoring aspect of this would be new work for OHS. And if there really isn't, bandwidth and staffing and a mechanism to do that, then any sort of recommendation of, what you would use as a measure, it's not as helpful. So the second half of this of, measuring the results of a consolidation, it implies that you're going to check it again in the future. And that usually hasn't been part of the CON process. It's usually a one-time thing with no future look back component. So that would be a significant change.
I guess the other thing that we did discuss as well, if you did this, we'd have to clarify the intent here. So is this for making better policy decisions in the future, or is there some enforcement component of this? And we haven't really talked that through. So if we establish a baseline and there's a CON approval that says you have to monitor quality, is there an expectation that it improves? And if it doesn't, is it even practical to have some kind of a consequence to the CON process, which is essentially a one-time decision to approve or not? But conceptually, we think monitoring quality is appropriate, assuming it's an accepted evidence-based standard.
Laura, did you want to chime in on just the, being able to, do something like that, your ability to do that in-house, and what you're currently working on in terms of measuring quality?
Sure, thank you. Yeah, I appreciate your work that your subgroup committee has done. You hit on, I think, all the points that we look at in our daily work. In terms of the ongoing monitoring, that is a topic that we have recognized is a place where we are lacking right now. We call that compliance monitoring. But as I think Pat was saying, is this more for enforcement purposes, or is this more for just making sure that we are, the healthcare providers are maintaining quality going forward? So in the past, I think it has been more for, compliance has been more for enforcement. And the only place that we've really looked at ongoing compliance is with agreed settlements that are not like Dr. Farquhar said, a one-time deal or a one-time shot. They are more of a, we're going to watch for the next 2 years, 3 years, even I think 5 years. We've had a couple of settlements. So this would definitely be new work for our agency. This would definitely need more people and experienced people. So in terms of, that's what I think about the ongoing monitoring. I was curious about why when you were talking and the points we're talking only about consolidations. I was glad that, Pat, you said that you were considering these recommendations or these comments in the greater context of CON in general, because I don't believe that consolidation is even a defined term in this part of the statute. So I think that that expansive decision or definition makes it easier to understand. In terms of leveling the playing field, so right now, I think you said that this most of our regulations apply to hospitals and healthcare systems. Who is it that we would like to make sure are also included? Is it smaller providers, nonprofit, mental health, substance use disorder facilities? Is that what you're thinking? I'm curious who you think we should expand to include.
So Lara, I sit on the physician practice work group as well. And so currently the folks who are not subjected to CON rules include many of the large payers who are also providers. Much of private equity is not included. And at the end of the day, those are the folks who are spending lots and lots of money to acquire these physician practices. And so again, if we're talking about truly limiting the growth of healthcare expenditures, improving quality, there should be a lens in terms of what's happening. Those are big, big players, and there's no monitoring whatsoever or scrutiny whatsoever.
Thank you for that.
And why is that, Jean? Why are they not?
So right now, they are subjected to federal rules. And so unless they hit the threshold for their Hart-Scott-Rodino, which is some multiples of millions of dollars, they don't need to be subjected to any regulation. So the question is, can there be state enforcement as well as changes to federal laws? Because a lot of issues have occurred because they've been able to escape loopholes related to these regulations.
Yeah, I would definitely be interested in exploring that further. So I will work on that for our next meeting. All right. So we are at a good point here to transition to Group B. Is Group B available to present today? I don't think I saw anything come in. No. Anyone else want to present anything today? Okay, so it looks like we got one preliminary recommendation, and I think it was helpful to have this discussion. Is there are any final comments based on anything we talked about, or anything we need to do different, or suggestions for improving the way that this task force has been operating? Happy to help.
Madam Chair, just a question on timing. I think our final report out date is January 15th. That we're supposed to have is that the date?
I don't know off the top of my head. Alex, do you know?
I believe it's the beginning of January.
Yeah, and okay. I mean, either way, we can work on this. we can have that final, report, but just know that, how we haven't, this is a long session. So if we were going to move anything forward through statute, either changing or updating current or, creating something new, our long session runs through, I think, the first or second week in June. So, don't feel too much pressure that this is the be all end all. Happy to continue these, discussions well into the first part of the year. So, all right. Anything else? No one's hand is raised. So we got off early today. Thank you everyone for your time, and I look forward to regrouping on Friday.